So as Heather spoke about, we're trying to use contact lenses as a way to deliver some drugs. She mentioned that when you put in an eye drop, you lose 95% of the drop very quickly, and a lot of that's because you blink. I don't know how many people have put in eye drops, but if you don't count what's running down your face when you're trying to put it in, as soon as you blink, you end up clearing a lot of that liquid. And since contact lenses stay on the eye, they can help improve that residence time. And so there's a couple of things that we need to consider when we're doing drug delivery. We need to make sure the drug is getting to the target site, and the eye is a little nice in that sense that you can actually access it, especially if you're trying to treat something in the front of the eye. It's pretty readily accessible. And we want to minimize how much of the drug is getting through to the rest of the body, because there tends to be some systemic effects from these drugs. So, like we've spoken about, topical drops are certainly the most common drug delivery method for anything in the eye. And the other problem, in addition to the fact that they're a little difficult to put in, especially if you think of people who are maybe a little bit older, or children are particularly challenging as well, people forget, or people don't want to do it. If you're already laying in bed, you may think that I'm not going to get up and go and put this in. And so there's certainly a poor compliance, especially for something like glaucoma, which is a long-term condition. And so if you're having to put in drops very frequently, it's easy to imagine that at some point you might forget, you might not do it as regularly as you can. So if we can figure out a way to make it easier for patients, we think that they'll be more likely to comply. And so, as Heather also mentioned, only about 5% of the drug is even really getting into the eye. So that means the other 95% of the drug is going somewhere else in your body. And so some of these drugs are pretty potent, and therefore you can get a lot of these side effects. And I'll talk a little bit later about diseases that we're looking to target in children. And with developing children, you don't really want any of this drug getting anywhere other than where it needs to be. And so looking at drug delivery and the pharmacokinetics of it, what you can see in these lines is, let's see if I can find a mouse, possibly not. So when you dose a drug, you get up to a really high peak, and then gradually the amount of drug decreases, and then you have to dose again. And unfortunately what happens is as soon as you dose, you tend to get a lot of the drug, and you can even overdose sometimes, so you're in a slightly toxic level. And often we don't hit at the very bottom, and so you can go through a period where you're underdosing, because you might say, okay, I'm only going to take the drug every 2 hours or 3 hours. And it's exactly the same as when you're taking a pill, right? The same pharmacokinetics are occurring, but there's a therapeutic window that we want to stay in between. And if we're able to hit these doses at the perfect time, we'd be great. But another option is for us to use something that will put us into that therapeutic window and keep us there for, like Heather said, her dream is to see something that stays there for a year in the eye. So you wouldn't even have to think about it. You've dosed it once, and it's just going to be in that therapeutic window the entire time. And so the example of where this is used right now is if you're attached to an IV. Okay, an IV can make sure that your therapeutic level in your blood stays exactly where it needs to be, because it's a pump, it's putting in a specific amount, but you can all imagine the downsides of having an IV attached to you for something that's not perhaps as dire as something you'd be in the hospital for. And so when you're putting in an eye drop, you have lacrimal glands and drainage that are moving the drug out of your eye into your nasal ducts and taking it away from what would be your site of action. And so there appears to be a lot of clinicians who are interested in using drug delivering contact lenses if we could make them. And the idea is that you'd put in the contact lens, and over the course of the day, your drug would come out of the contact lens. It's next to the eye, so more drug would get into the eye, and you're not going to have that same drainage that you would have when you're just using an eye drop. But of course, this depends on how much drug you have in the contact lens and how quickly the drug can release. And so this is sort of a game that we play a lot in our lab, where we're trying to put drugs into the contacts and make sure that they don't release too quickly or they don't release too slowly. Because even though I'm sure I'm guilty of it, and I'm sure many people who wear contacts in here are as well, you're not supposed to wear your contacts indefinitely. They are supposed to get thrown out at some point, and it's often 2 weeks or a month. And so we want to make sure that that's really the window that we're looking to deliver these drugs in. And so if we're able to do this, we'd have the right concentration, we wouldn't need as much drug to do it, and we'd have fewer side effects, which would be beneficial to both the cost and the treatment of the patient. And so one of the ways that our lab has looked at doing this is by incorporating the hyaluronic acid into the silicone hydrogels. And what they've noticed is the amount of lysozyme is decreased. So that's the protein that sticks to the contacts, and if you're a contact lens wearer, that's why you're supposed to rub them at the end of the day, and it's also why your vision can sometimes get blurry at the end of the day. And what we looked at doing here was taking this hyaluronic acid and having it come out of the contact lens. So as the day wears on, you have something that's a wetting agent coming out and making the contacts feel better towards the end of the day. And the reason we target the end of the day is that tends to be when contacts are most uncomfortable. When people really are saying at 6 o'clock, I need to get these out of my eye, they're really causing a problem. So if we had something that could be released from the contact, as your eye gets more sensitive, you're going to be able to have something there that's going to take away that problem. And this graph at the bottom shows that over time we can make a contact lens that still is releasing a little bit of this hyaluronic acid. And so we've also been able to use HA to control the release of another drug. So these studies were done with timolol, which is used to treat glaucoma. And what we've been able to show is that when you incorporate hyaluronic acid and timolol, you can actually adjust the release profile. So it lets us either speed up the release or slow it down, depending on what you would need for the treatment area. And there's different types of drugs that you could use for this. Timolol is a hydrophilic drug, which means that it's often hard to slow down the release. So if we can slow it down by incorporating it with some other molecules in the contact lens, this will be a better drug delivery system than just the timolol on its own. And so that's sort of where a lot of the research is right now, is trying to figure out ways that we can slow down the release of timolol. And another way to do this is to make the materials with timolol, soak all the timolol out. And the reason this is also important is because, as Heather mentioned, part of the problem with polymers is that you can have very small amounts of initiator or monomers left over that over time can cause toxicity. So we need to often soak these materials to get rid of any of those releasable agents. And if we're soaking them and we're getting out the drug and we're getting out all of these negative components, that's great for us. And what we've found is that we can reload the materials with even more drug than we started with. So the timolol enters into the lens, and now it's another way that we can tune the delivery so that this might be a better option if you're looking for a specific speed, or if you had a concern about the initiator or something like that in the materials. So this is just showing here that we're able to control it with this other step. So some of the work that I've been doing looks at myopia, which is short-sightedness. The light focus is a little too early, and we see a blurry picture. And this is one of the diseases that's, well, I guess the only disease, that's corrected with contact lenses and glasses. The reason why we look at this, and in particular in children, is because in some populations, the prevalence can be up to 90% of the population that actually suffers from myopia. And many of these people suffer from a very severe form of myopia, where they can actually get complications like retinal detachment, which can lead to blindness. So there's a reason for looking at this beyond, I just don't want to wear glasses or contacts. And in a lot of the worldwide population, access to glasses and contacts isn't necessarily readily available. So if there's something else we can do, that would also help. And I also looked at retinoblastoma, which is an ocular tumor that often affects children by the age of 3. And it shows up in pictures as a white mark in their eye. And there's a hereditary condition that children can suffer from. And if they have this condition, they're 95% likely to get multiple tumors in both eyes. And so while the treatment for one tumor might be to actually take out the eye or to treat it with traditional forms of cancer treatment, it's not a great option for these children who we know are going to get multiple tumors. And so we were working with a group at U of T to try to develop a way to prevent these tumors from forming. And we were looking at a way that we could deliver this in children. And so we looked at two drugs. We looked at atropine, which is used for the treatment of myopia, and riscovatine, which is used for the treatment of retinoblastoma. And we obviously, as I said before, didn't want to do it systemically because of the toxicity. In particular, riscovatine is a CDK inhibitor and is actually used as chemotherapy at higher doses. So you certainly don't want that in a child if it doesn't have to be. The topical application, we expect these drugs need to work at the retina, and so like the 95% loss is not a great thing here. And we looked at other methods like intraocular implants or intravitreal injections, and both of these are particularly invasive with children. And in the case of retinoblastoma, the doctors really don't want to pierce the globe if they can help it because they're worried about the tumor spreading. So in this case, we were looking for that local delivery, the controlled delivery, and of course that we wanted it to be able to be used in very small children. Retinoblastoma, if we were going to treat it, to prevent it, we were going to be looking at kids almost the day they were born. So it's a pretty unique population. And so we first tested to make sure that we could get the drugs through the sclera, which is the white part of your eye, because that was our drug delivery target. We were going to put something in the sac of the eye, and we were going to use that, similar to how a contact lens with drug delivery would work, to diffuse the drugs into the back of the eye. And so we tested this with porcine eyes, which are oddly very similar to human eyes, and we were able to show that we could get a nice slow drug delivery profile. And in particular for riscovatine, we were looking at trying to target about 7 days for drug delivery. We had some problems with the first material we used. We used almost like a blood clot without the blood cells. And we moved on to lipid-based materials. And these materials are pretty interesting because they're able to be thermally controlled. So you would start with something that could actually be like liquid at room temperature, and it could transition at body temperature into a cubic phase. And so these are examples of cubic phases where the red in the picture is where the water would go and the white is the material. So you actually get these water channels flowing through the material. And what we wanted to do was combine the drugs with the lipids so that the drugs could diffuse into these water channels and diffuse out of the material and get into the eye that way. And because that's a pretty tortuous path, it was going to take a little bit of time, and that's how we'd be able to control the drug release. So we looked at these two lipids, which are both found in the body, and we discovered that we had to make mixtures of them because the properties of each lipid independently weren't quite right for body temperature. And so we were able to mix them and show that we could actually tune which temperature we got the cubic phase at. And we were able to show that depending on how much water we added, we could modify the cubic phase. So the reason why all of this is really good for us is it gives us a lot of parameters that we can tune to try to change the drug delivery. Because how big those red tubes are is going to affect how fast the drug comes out and ultimately what that delivery profile looks like. So these are all things now that we can alter, and because we have control over them, we can ideally tune the delivery, even particularly for a patient or for the disease in general. And the other really neat thing about these materials is we can make dispersions of them. So we can actually form something that would be easy to inject. So in the case of retinoblastoma, not something we're looking to do. But for another disease condition, we might actually even be able to inject these lipids as little nanoparticles. And so we've done some drug release profiles with these. And you can see from this profile here that we're able to get a nice slow release. And that's exactly what we want, so that the amount of drug coming out at any point is similar to the next time interval. So that's a nice linear profile that really gets me excited. I'm not sure what it's doing for you guys, but this is why I come and sample at 2 in the morning. And so as we can see, we're able to get some release over time. And the nice thing about these materials is they do degrade. Because they're lipids that are naturally found in the body, they're able to be broken down and processed. And what we actually end up seeing, and towards the end of this, you can see that the results start to go up again. And that's from the degradation of the lipid. So there's a little bit of drug that's still held in there, and it's able to come out at the end as well. So changing gears now towards diseases that are on the retina, there's a lot of problems with the retina, and this is where, as Heather mentioned, it's really hard to treat. There's not a lot of really good options here, but there are some devices that are currently in trials. And one of the big diseases that has a lot of prevalence and is really debilitating is age-related macular degeneration, or AMD. And this takes away your central vision. So it makes it virtually impossible to read anything, to drive. And so you can imagine that if you couldn't see anything right in front of you, how much worse that is than if you start losing things on the periphery. It's also painless, which means that people don't necessarily seek treatment until the disease has progressed a certain extent. And there's two types. There's wet AMD and dry AMD. And wet AMD is caused from abnormal blood vessel growth and leakage, whereas dry AMD is the breakdown of the cells on the retina. And the biology suggests that everybody who's ever had wet AMD has had dry AMD at some point. And while dry AMD is more common, there's no treatments currently available for it. So this is sort of a picture that shows what the retina would look like. In dry AMD, there tends to be spots, whereas wet AMD, there tends to be fluid. So these here are two retinographs that are showing the dry AMD and the wet AMD. And an example of what it would look like if you were looking as somebody would with the condition. And you can see the big black missing spot on the picture on the far right. And so as the disease gets worse and worse, it takes more and more of that central vision. So the easiest way to target the retina is to inject things into the vitreous. And this is what Heather was saying, that some people sign up for to go for monthly injections for AMD. And you can imagine people who are older thinking, I'm not doing this. So there's people who find this treatment so invasive, they would rather lose their vision than continue to go for treatment. And so that's really not a great sign. And certainly anything you can do to help this population would be beneficial. So for wet AMD, there's two drugs that are currently used. One is substantially cheaper than the other. And then for condition related to diabetes, DME, there's some other drug options as well. And most of these drugs, so the only things that are available right now are through sustained release implants. And that's something that we'd sort of be looking to do as well, so that you'd put something in the vitreous and it would very slowly release over time. And so sort of in some ways summarizing to what's been said, so you can use eye drops, you can use these implants or these injections, and there's one other way that we'll talk about at the end, which is a subretinal injection. So you actually inject right behind the retina in the eye. But all of these are options, and all of these are being looked at as possible delivery methods and have some pros and cons to them. So one of the devices to come out of our lab that's pretty exciting is a polynipam based polymer. And polynipam is a pretty cool material because it is liquid at cooler temperatures, and at higher temperatures it turns into a gel. So the picture on the right here shows the nipam being injected into heated water. And you can see that once it hits the water, it begins to solidify. And so we're trying to make polymers that exploit this injectability. So you don't have to cut into the eye, you don't have to actually implant anything, you can inject it in. But once it's there, it creates a very stable mass, and we can have slower drug release from this. And so the original materials were made using 4 components. And because people might be 50, 60, 70 getting these materials, even though we consider it to be a somewhat elderly population who suffers from this disease, if these materials are going to last for about a year and you're going to have to do it again, you're going to need the material from a year ago to at some point start leaving the eye, right? We don't want these to be permanent materials. And so by incorporating this DBA, it's able to undergo a ring opening, as you can see in the bottom right picture, and that actually causes the whole thing to go back into a liquid form, and the body can clear it at that point. So there was a way to sort of introduce some degradability into this polymer. And so there was a lot of characterization that was done on this material. In the upper left, it's a graph that shows how the polymer is degraded, so you can very clearly see the dots. After about 130 days, about 85% is left. So it shows that it's very slowly degrading. And the SEM pictures on the right sort of match with that you can see that there's some degradation, but most of the material remains intact. In the bottom left, there's a picture of a drug release, and that was looking at dexamethasone. And again, you're able to get this sustained drug release over many, many days, which is something that we need in a material that we're hoping to inject once and stays for a year. And there's histology samples on the right, which showed that there wasn't much adverse reaction to these materials. And these materials were injected initially subcutaneously, and because they tend to spread really nicely, they're really hard to take back out. So the liver and the spleen samples were examined, and they showed no adverse effects. And with the injection site itself, there was some initial response, but it was about the same as in the sham injection as the material injection. So it shows that these materials appear to be safe. The problem is that they're not clear. And so while it's possible that whatever you inject would stay out of the visual field, you don't always want to risk that. So we work to make these materials clear by incorporating PEG, polyethylene glycol, into the chain. So went through a lot of iterations to try to make a material that had the right properties and had some success. So we were able to make materials that were liquid at room temperature, which would make them injectable, and then gelled by 37 degrees Celsius. So by the time they were in the body, they'd be solid. And these were optically clear. And so a lot of characterization to show that things are degrading as they should, and the histology to show that these materials also appear to be safe. We also included some cells, because one of the other applications besides just drug delivery for these materials is the idea of cell delivery. So if you wanted to repair the retinal layers right now, one of the targeted cells is RPEs, the retinal pigmented epithelial cells. And since these appear to die off in some diseases, right now the only options to replace them are with an injection, and they tend to not live very long because they're not adhered to anything, they're adherent cells. And the other option is to implant a cellular sheet, and that's about as invasive as it sounds. You have to peel everything back, lay down the sheet, put it all back, and hope that it takes. And so this method might be able to sort of be a hybrid if we can have the cells adhere to the material, and as the material degrades, the cells reintegrate into where they should in the retina. So these injections here were done intravitreally and included some cells, and again, there's no pathology shown. And this was done with a collaboration at UBC that looked at doing a subretinal injection, so injecting this material with the cells in behind the eye and seeing if there was any issues. So far, the results look very promising. There was some detachment with the initial injection, but that seems to go away. And so by being able to potentially get the cells into this space, it would make it very easy for the cells to integrate into the retina because they'd be right against it. And so there's no worry that you're losing cells to areas where you don't need them. So this was sort of very promising results. So in summary, we've got a lot of materials that have the potential to treat many different vision disorders. And we have to get a little creative with the ways that we're going to deliver these drugs. Contact lenses are a great potential delivery device, but because they overcome the limitations that exist with eye drops, but there's still a little bit of work to be done before we can use them practically. And with these other responsive materials, they're a great option because we're able to tailor the release. There's a lot of things that we can tune on them, which means that we can potentially use them for a variety of different disease conditions. And it allows us to target a long-term treatment, which possibly to the dismay of ophthalmologists will keep people out of their offices, but should benefit the patients. And of course, like everything in medicine, it takes a very long time, but it's certainly worth the time. So as Heather mentioned, she created a network 2020, and these are all people who have participated in the network, who have helped with funding of many of these projects. And that's it.